and a certified microbiologist with more than 40 years of experience in healthcare quality, safety, infection prevention, and clinical microbiology in a variety of settings, including large hospital systems, and more importantly, in rural and critical access hospitals. She's also worked in ambulatory care, acute care, and surgical services. She received her master's degree in infection prevention and epidemiology from the University of Washington in 2007, and a master's degree in hospital administration from Troy University in 2008. She graduated with her undergraduate degree in biology and microbiology from Gonzaga in 1977. She is currently a certified medical technologist from the American Society of Pathology, and she's certified in infection control from the Certification Board of Infection Control. She is presently the infection preventionist at MultiCare Health System, and her specialty is surgical services. She's also the past president of the Puget Sound chapter of APIC, and she's serving as a member of the executive board of the APIC chapter as well. Jeanette, welcome, and take it away.
Okay, good deal. So I'm just giving you all a fair warning. There are 77 slides here, so I'm going to be talking pretty fast. We are gifted with 90 minutes, so hopefully you're sitting on a very soft chair. So here we go. We're going to talk about infection prevention risk assessment in your facility. So first of all, what is a risk assessment? It's an assessment that examines a process in detail, including the sequencing of events, and I hate to read these things, but there it is. You know, and what it is where you assess where your facility has been in the past, and specifically what's happened in the year before, and then you find out what the situation is currently, and then where are the risks, what you need to do, and then this helps you decide on a plan moving forward to deal with problems that you have. Now, this is the Joint Commission risk assessment definition, and it's really good. And even though a lot of you are probably not Joint Commission members, that's just fine. The truth is they do a really good job at giving you very specific things of what you need to do. And so you don't have to be a member, but definitely, you know, we're going to talk about this because it's just I feel it's a really good way of managing and going through this process. So just to give you a heads up, what I've done in the past is I come from, initially, I started infection control in a critical access hospital. You know, I used to say that we had a busy day when we had 38 people in the hospital, you know. So that was, I'm sure, similar to all of your circumstances, okay? When they asked me to add infection prevention to my duties in microbiology, I said, yeah, sure, you know, I can do that. I think that would be a great thing to do. I'd love doing it. I said, but give you a heads up, I'm going to run this program as though we were a Joint Commission hospital. And of course they said, well, we're not a Joint Commission hospital. And I go, I get that part. But I do know that they do a really good job, and that is like the gold standard, and so that's the way I'm going to run it. And so before I signed on the dotted line, I gave them a heads up, this is how I was going to do it, and that we were going to do this together. So there it is. So we're going to talk about the recommendations here. So this is what risk-based planning is all about, and what the Joint Commission expects. So there's a four-step process to this. First of all, you do the risk assessment. That's where to see where you are now and what happened in the past. And it's not just about infections, believe it or not. You're doing infection control, but because there are so many factors that affect the infections in your community and in your hospital, you have to look at a lot of other things. That's the first step. Then there is a goal. Where do you want to go? You know, what is the ideal situation? What do you want to do? And what do you go? And then there's the implementation. How are you going to get there? What is the road? What is the path? You know, what is the way you're going to get to that goal? And then an evaluation is, how did you do? You know, then toward the end of the year and throughout the year, but toward the end of the year when you start thinking about the next year's risk assessment, You have to go back and say, did we meet the goal? Were the things that we did to prevent infections, were they effective? You know, and you can't just go on. You know, so many of us very often in infection control, you know, we just counted things. We said, well, we had this many infections in the surgery, we had this many collabs, we had this many UTIs, and we really don't assess what we're doing and if it's appropriate or if we have to change. And that's what the Joint Commission is really interested in. Is they know we get infections. They know that that happens. What they want to know is, what are we doing to make it so that it gets better? You shouldn't just keep doing the same thing over and over again if it's not effective. So that's where it is. So then you start that whole process all over again. So this is the first standard. You know, the hospital identifies the risks for acquiring and transmitting infections based on the following: your geographic location, your specific community, and the population that is served. And so you have to identify the risks on the care, the treatment, and the service that you provide, and the risk for acquiring, transmitting those infections on the surveillance activities. You know, what are you looking at? So the first step is to find out what your risks are due to your geographic area and your community, and then what are you going to do about it? So that's the first thing. And here's some more standards. You review and identify the risks at least annually. So if you walk in the door and you're a brand new infection preventionist, you know, what is going on right now? And then what happened in the past? So you have to get all of this. So you have to have input. So this is not just your job. That's the most important thing you need to learn right away, is you might be the infection preventionist, but in order to do this, you need input from a lot of people in your facility. At the minimum, obviously, the infection control personnel, and for most of you, that's just you. But you have to also talk to the medical staff, to your nursing staff, to the leadership, you know, EVS, all of that. They are all included in this. And then you have to prioritize the risk that you've identified for transmission, and that you document all of this. And then based on these risks, you set the goals, you know, just like we've already talked about. So these are the standards. And so if you take these standards to your administration, then you can say, well, this is the way we need to do this. So this is another standard. Based on the identified risk, the hospital sets the goals. You know, a written infection prevention and control goals include the following: addressing your prioritized risks. So I'm going to say over and over again, don't try to boil the ocean. You know, it's very intimidating. If you're brand new to this, you feel like you're drinking from a fire hose. So what your risk assessment does, it helps you focus on the top three, for instance. Just take the top three infections that you have to deal with and focus on that. That doesn't mean you don't look at anything else, but those are the things that you want to focus on reduction for the coming year because of your risk assessment. So then here's another standard: evidence-based practice. So what's that mean? So a lot of times, once you're identified as the person in your facility to do infection prevention, you're going to get a lot of phone calls from a lot of vendors, and they, you know, will provide you with all this really cool stuff, most of which is outrageously expensive, and a lot of it, believe it or not, is not evidence-based. So, you know, you have to learn what to look at. So we're all about data, and we're all about evidence-based. So you can't just change out. I swear to you, I got this. I got a phone call from a vendor who said if we change out all of the handles on all the patients' doors to brass handles, that all of our infections are going to go down. And, you know, and the first thing out of my mouth is, okay, show me a study, and I get that metals, you know, work, but, you know, at $1,000 a pop, that's not going to happen. So, you know, you have to use evidence-based. And so you use this based on the result of the risk assessment that you're going to do. Plus, you have to educate your staff and make sure that, you know, you gather all that information that you need in order to make this happen. One more standard, implement. So it's not just about saying, okay, we have this risk, this is what we need to do. How are you going to implement that? You know, so you actually have to come up with a plan to make things happen. Cover, for instance, like PICC lines, you know. It covers short and long-term central venous catheters and peripherally inserted PICC lines. So that's your specific. And then what you need to do is how many of those are you putting in? How long are they staying in? What are you doing to reduce the infections? How quickly are you getting them out? All of these things are measurable. So the risk assessment are conducted in time frames defined by the hospital, meaning that, you know, you can do it every 6 months if you want, or you can do it every year. It all works. Another standard, implement evidence-based practice for preventing surgical site infections. So the first one was about CLABSIs. This is about surgical site infections. So, you know, this is all part of your risk assessment, and we're going to go through all of this. So tools. The cool thing about the Joint Commission, or you can call it the difficult thing about the Joint Commission, is they don't tell you exactly how to go about this. You know, they don't say fill out this form and make sure you've got all of this covered. No, they're not prescriptive. You can use any kind of tool, and there are a lot of tools out there, and we're going to talk about those. And you have some examples, and I have links to those tools, and we're going to talk about them. So it's not about just one type of tool. Some of you will be able to use one tool, and some that won't work. You'll have to use a different tool. So you have to kind of look around and see what's going to work for you. They also aren't prescriptive about how you get this input. You know, it can all be email if you need to have it that way. If you're geographically very distributed, a long way apart, go ahead and use email and phone calls. That's okay. You don't have to have face-to-face meetings, although I encourage it, but that's because that's my experience. And it doesn't say who you should report this to. I will tell you that absolutely, positively, your administration needs to know about this, so that when whoever comes to do surveys at your facility, that you can get your hands on this, and they can get their hands on this, and you can show this to them, because this puts a big smile on any surveyor who walks in your door. If you can show them this, they're going to love it. So the tools, they will expect you. That is well designed. So what does that mean? Well, if it works for you, then it's well designed. That it's credible, so you're not just putting data in that you don't have resources for. You know, you have to go in and look at what's really happening. It helps you to develop your infection control plan. So this is the bare bones. This is the skeleton that you base your whole infection control plan on for the coming year. And it should reflect what you've discovered in your risk assessment. And it includes all the required elements, so all of the possible infections that you should have available, that you have to worry about, right? CLABSI, CAUTI, surgical site infections, VAP or VAE, or transmission of multi-drug resistant organisms. So, and that it's actually used. It's not just on paper. It's something that actually reflects what's happening. So when the surveyors, either the health department or the Joint Commission or anybody shows up, CMS in your facility, that they can see that you're actually living this document. It's not just something on a piece of paper, and it's in your file and you don't actually look at it. It prioritizes your risks. It uses your infection prevention goals. It actually shows what kind of activities you're going to be doing. It talks about communication to your patient safety program. So it's not just about infections. You need to integrate this with your patient safety program. And if you have findings that don't fit in with the plan, you need to revise it and adjust. You know, so if a volcano, like in Washington, we have those. If a volcano goes up, and if your infections due to various, like there's more particulates in the air and you don't have filters on your hospital and you're getting VAEs or VAPs in your ICU, then you need to adjust, and you have to show that in your risk assessment plan that you've changed it. So what's the process? The first thing you need to do is homework and planning. So this takes time. And even though, you know, you're a critical access hospital and you don't have that many beds, actually your process is no different than if you're in a large system. It's all the same. You have to get all the forms together. You have to get your standards that you want to cover, you know, and in Washington State, obviously, it's SSIs, CLABSI, CAUTI, you know, and MRSA and C. diff. What is your data? What's going on? What's happened in the last year? And what are the current issues that are happening right now? You know, so if Mount Rainier should blow, you know, you need to have that in there. You can't just pretend it's not there. Of course, if Mount Rainier blows, we're all in trouble. So, here's the process. So team recruitment. So this is not just you filling this form out. You need to get a lot of people involved in this, and you have to gather your data and gather your people. So this is exactly what we do, okay? Hi, this is Jeanette from Infection Prevention. It's time to get ready for yearly risk assessment. We actually say this. Please evaluate this following information. So with your EVS, for instance, you want to know how many admits, how many discharges, how many times were the rooms cleaned, and what are you using to clean the rooms? You know, if you've added a new process, for instance, for using bleach, to clean all C. diff rooms, you need to address that and say, okay, did we have a reduction? Did it work? And make sure that if they cannot attend in person, to make sure they get this data to you. And if they can't come, please send somebody who can, because trust me, questions come up, and if you have the people in the room who can answer those questions, it's so much easier. And then in the infection prevention department, now if you have more than one, then you're lucky. But you know, make sure that everybody who's involved in infection prevention is in on this also. We'll be meeting to work on the 2006 risk assessment on this date. Bring all this data that you're involved in and information concerning your area of expertise. So for instance, I do surgical services across our whole system. And we've got 5 hospitals and 5 ASCs and a lot of various, you know, other sites and everything. So what I always bring to the table is the surgical site infections that I officially have to follow, but I also bring to the table the infections that are cropping up. You know, you don't have to report those, but that doesn't mean that you don't look at them and go, I think we've got a problem developing here. So it's things like that that you need to bring, okay? And then what are the most frequent reasons for admissions to your hospital? What procedures do you perform? How many CLABs, how many central lines do you put in? How many vent days do you have? How many Foleys do you put in? All of that stuff is very important. So this is what a typical team can look like. So of course, in a critical access hospital, you know, there are some people wear many different hats, which in many ways for you, that's really easy, makes it easier. You don't have to have that many warm bodies in the room, you know. For a place like ours, there's a lot of warm bodies in the room, and it makes it difficult to get everybody there, you know. But if you've got one person who's in charge and manages housekeeping, maintenance, and a quality department, then, you know, that makes life that much easier. And so there's pluses and minuses for everything. So the meeting is mandatory. If you don't show up, you need to send somebody, and it's that's how important this is. You know, you can't just dial this in. You got to be there. It takes time, so we take a whole day, and we start at 7 o'clock in the morning, and we sit down and slog through this and get through it by the end of the day, and we have food available. So there's biological breaks, but that's just about it. We prioritize the risks, and we sit down, and after we have identified the risk, we prioritize them, and then we come up with a plan. And of course, it's all bare bones, and there's a lot of notes. There's somebody there who takes notes so that we don't have to do all of this. but definitely, you know, this is a heavy-duty work day. And I'll be very honest with you, all of us, we just roll our eyes and they go, here we go again, you know. But this is a big part of what we're going to do for the next year, so it's important to get it right. So what do you do? How do you start? Let's start here. Geography and your environment. This is specific to your facility, and that's interesting. So it's not, notice this, it's not just within the four walls of your facility, okay? It's what's happening in your community. What about the, who are you serving, okay? So is there a specific geography that is specific, something to just to your area? You know, if you live in the desert part of Washington State and there's a lot of dust, for instance, you know, you need to take that into account. Are you changing the filters, for instance, in your air intake? You know, that's important. So it's things like that. Do you have endemic infections? What lives in your area all the time? So this is really interesting because, you know, it's all stuff that we live with bacteria everywhere we go. And some of us live with more bacteria than others, and you need to address that population. For instance, if you have people who live with mice, and there are a lot of people who live with mice, and I live in a rural area, even though I work in a city in Tacoma, you know, I live in a rural area, and so I am aware that the deer mice who live in the fields during the most of the year do try to come into my house at the end of summer and before winter starts. And so we have ways, we always are very diligent about making sure that they don't make nests in the house. But there's a lot of people who don't have that available to them. So you always have to have at the back of your head that you might have a hantavirus that walks in the door, you know, things like that. Area endemic infections. Other related risks, you know, are you a port city or a port town? Do you have a major highway going through your area? Do you have a volcano? Hello, it's Washington State, and there's a lot of volcanoes around here, and this is a part of what happens to you. We are all need to incorporate the possibility of an earthquake in our risk. And how are we going to get supplies to our hospital if that should happen? The medical care characteristics, what type of facility do you have? If you just do, for instance, if the surgeries that you do are basic, pretty non-invasive stuff, then this is a little bit easier, you know. But if you're doing total joints, you have to address that. You know, if you're doing that, hopefully, you know, you're not doing big open heart surgeries if you're a critical access hospital, but if you are, absolutely, this has to be part of your plan, okay? And make sure that you address all of that. So go to your surgery center or to your OR and see what is the top 3 surgeries that you're doing, or how many Foleys are you putting in? How many central lines are you putting in? What are their sites? What's happening? So all of this is a big part of what you have to figure out. Organization evaluation. So you have to have a description of your facility. What characteristics increase the risk for infection? What characteristics decrease your risk of decrease your risk of infection, and make sure you put all of this in your assessment tool. It's all part of it. So the form components, and we're going to talk about various forms. So what you're basically doing is you are trying to foretell the future. You know, get out your crystal ball. What is the probability of this event happening? So there's an impact and severity for this, both health for the patient or for your staff. Don't forget your staff. There's a financial impact. There's a legal impact, hopefully not too much. There's also a regulatory and accrediting impact, and you have to look at all of that. And you have to look at what's really happening in your facility. So when you boil all of this down, you come up with a risk score. And what this does is it helps, it's a multiplication, and it takes all these various components and boils it down into one number and makes it so that you can actually figure out what you need to focus on. So there's a group consensus, obviously, in order to come up with this. But what this does is what someone will think is a 2 needs to be a 2. Someone else will think it's a 4. And so you have to come to a consensus. What do you think is the highest risk? And you talk about this and argue sometimes back and forth so that you can come up with a number and then plug that into the form, which we're going to show you here. So what this does, it ranks in order the risks and gives you risk scores so that you can find out what you need to work on. And every organization's risk priorities are going to be different. You know, if we're having a big problem with colon infections at one of my facilities that I watch, well, then that's going to be a risk for that facility, and that's where I'm going to focus most of my attention in the coming year. If another facility has a lot of colons, they do a lot, but they only have 1 or 0 infections, well, I don't have to focus on that, okay? It's not that I ignore it, but it's like a lot of my effort for the next year is going to be on this one facility that has a lot of problems to see what's going on, why is this happening, and what can we do to fix it. So, for instance, Tacoma, at Tacoma General, where one of our facilities, it's an inner city hospital near a major port, and it has a different set of risks than in a community hospital, such as another one of our hospitals is Allenmore Hospital. It doesn't get a lot of that exposure to the port, and so you have to change what you do. They can share many risks, these various hospitals, such as multi-drug resistant organisms. We all have some of that. And, you know, just because you're big doesn't mean that you have more problems. Sometimes you have fewer problems in relation. And you're in a small hospital, if you have, you know, 4 or 5 infections all in 1 month, that's a very big deal. And so you have to be aware of that. Some of you have a large population with no medical care, and we certainly have that. And I know in the rural area and in critical access hospitals, this is very true. And a lot of you have migrant populations, so they don't often have medical history when they walk in the door. You don't know them, they don't know you, and you have to start at ground zero, and you have to take all of that into account. So let's talk about the exercise. What you do is you discuss each potential risk, you come to a consensus and assign a number for each of these components, and then you do the math and multiply it out in order to calculate your risk score, and then you compare your risk score to validate with the group. So everybody, you know, you go, so I come up with a risk of 10 here. Do you guys agree with this? Is this something that you know, sounds probable? And if everybody nods their head, well, then that's a good number. So once you have your risk assessment all done, then you come up with your infection prevention and control plan. So you develop a plan for each of these with the people and the resources that you have available. You have to put in a timeline, and you have to put in a goal. You have to get, so once you figure this out, you take this to your infection control committee, which has a lot of various people on it, and you say, here's the risk assessment. Don't just bring it to the meeting for them to look at it cold like that. Send it out a week or 2 in advance and get their input and approval on it before you finalize this. And, you know, obviously you share this with your administration. You know, partnership with the key staff. So there's always a nurse in one unit who knows what's going on. You know, they don't even have to be the manager or the director, but they have the pulse of that unit and they know what's going on. And make sure you identify those people and get them involved in this. And like I said before, don't boil the ocean. Don't do it all. You know, you have to kind of keep an eye on everything, but you know what this tool does, it helps you to focus with a laser eye on the things that you have to work on for the next year. And so that's what you spend most of your time on. You make sure that there are objectives, that you're measuring things, that you evaluate how you do throughout the year, and don't be afraid to change it if it needs to be changed. If you were totally wrong. Say all of a sudden MRSAs fell off the face of the planet and you didn't have any. So that's good, right? So you can focus on something else. If you've got that down and all of a sudden the transmission in your facility just stops happening, throw a party and go on to the next problem. So you should have a progress report. You order your priorities, you have a goal, make it broad. Don't make it too specific because you can box yourself into a corner. Make sure that what you're looking at is actually measurable. You know, don't make it a fuzzy thing. Make sure that you're measuring it. Have a strategy to take and to achieve this objective. And then just check and see how you're doing throughout the year. And like I said, if things change, adjust with it. You know, it's not in concrete. Go ahead and make adjustments through it. Document those changes, though. Make sure that in the plan that you've already said, you know, put in a time frame, you know, on this date at this time site, June 2015, you know, the MRSAs disappeared. We did not see transmission in the last 4 or 5 months. So we're moving on to working on this goal now for the next 6 months. And if you have that in your plan, then when your surveyors show up, you know, you can show this to them and they can see that this is a living document. So once you've found the top 3 risks, then you develop a goal, objectives, a strategy for making that happen, and a way of evaluating what's going on. So you document your progress and the process. Make sure you have group involvement and organizational support. So by all means, those of you who don't belong to APIC, you know, get with others in your area to figure out what the group is. You know, it's a lot of you share responsibilities in your facility across facilities, and you become friends, and you can see what their problems are and what they're doing. Make sure you have forms. You're doing all the right things for reporting, and you track your results. Tracking and trending is a big thing in infection prevention, and for the most part, you know, if you're doing the right thing and the numbers are going down, then you should tell people about that. You know, if, for instance, C. diff, I don't know if the rest of you are seeing this, but we've got one facility that all of a sudden our C. diffs have just gone sky high. And we just had that meeting this morning. And so what we've been doing in that facility is obviously not working. So here we are mid-May, and we're going to totally change what we were going to do. There is one of our facilities who's doing a really good job. It's not going up. It's not going down that much, but it's at least staying level. So we're going to get together with what they're doing to make sure that, you know, we're spreading that best practice across the system here. So you can do this too. If you've got one unit who's just rocking this and they're reducing infections and they know what they're doing, then, you know, identify that and put that in your plan, and that you're going to move what they're doing to other units. You know, like I said, this is a live document. Go ahead and document at time frames what things have happened and what you're going to do. So let's do a risk assessment tool, and I'd love to do this during the presentation, but I do have a pile of screenshots, so this is good. And you have this form. This is actually a rural risk assessment document. It was put together by a friend of mine, Sandy Kangas. She was awesome. And so we've, you know, spread this out to the rest of the critical access hospital. And this is a really cool document. It's an Excel file. And as you change these numbers here, you know, the number down below in that little red box in the lower right-hand corner will change. And we'll take a look and see what this looks like. Okay. So here it is. This is the first one. So device-related infections, right? Your bloodstream infection. If the probability of having a bloodstream infection in your facility is low, then put in a 1. The human impact for this, if they should get it, obviously, is high. The possibility of death or injury is high, you know, pretty certain. property impact, you know, property impact is not that big a deal, so let's call that a 1. The business impact, well, could be moderate, could be, you know, it could be that, you know, your patient's family is really angry with you and they take you to court, so then that would be a 4. You know, has that happened in the past? And that's usually what happens. Put a 4 in there. If it doesn't happen that often, but, you know, you have to change what you're doing, your practices, and you have to bring in a new product, for instance, then it would be a 3 for high. You know, let's just go with a mid-range here. So here's your preparedness. So these are all the things here in the purple that make the score go up, right? On the right-hand side, the preparedness, or the things that you are able to change, practice, and alleviate the damage, the higher this is, the better your risk is. So let's say that you are prepared, you have a program in place, you're monitoring your CLABSI, you're scrubbing the hub, you've got eyeballs on what's actually happening, you have a very robust program, then you get a 4, okay? And that you're prepared should it happen. The internal response is a rockin' number 4 here. So you are certain that you are going to make certain that this is happening all the time. The external response, so say for instance that this is something that the community can help you with, you know. Say you have an education process out there in the community that helps your patients when they're not in your facility to reduce bloodstream infections, you know. Patients go home with central lines, you know, we all know this. Do you have home health that goes to the patient's home, and are they well versed in the prevention of CLABSI? If they are, then you put in a 4. If you don't have that much, or it's somebody else and you're not aware of what their practices are, then you'd put a 1 in here. And so when you add all of this up and the math is done, then you come up with a risk score, and that here is a 4%. So that's pretty good, right? So next. So see what happens when you change the numbers. So the probability, if these happen, if you've got a high central line infection rate and that, boy, if patients get a central line, you're just crossing your fingers and saying your prayers that they don't get an infection, then I'd give that a 4, right? That's a probability, a bad thing. Human impact, a 4. Property impact, it's a 1. Business impact, a 2. We've kept those the same. Are you prepared? Yeah, I'm really prepared. I'm doing everything I can, and we're doing a good job. We have a high internal response, and we don't have a lot going on in the background. See how that number changes? By changing this number over here on the left. So here's a few more that I filled out, just for example. So VAP, you know, if you don't have patients that get vents very often, then this is a 1. Right? If you're not venting patients, they can't get an infection. So that's really good. You know, the impact on these are pretty good. 11%, look at this, urinary tract infection. If you put in a lot of Foleys and then, you know, they get infections, it's a human impact. Properties, not that much. Business impact, we're still in the middle. Preparedness, oh, you've got a 2 on that because you're not doing maybe that good a job. Internal response is even worse. Holy cow. External response, nothing there. All of a sudden, look at that, you got a 28% there, which means probably that it's something you need to address. So here's just a couple more implants from surgical procedures. If you don't do it that many implants, it's not a big deal, right? Huge human impact if there's an infection. Property impact, this could be a problem also, especially if they're readmitted, which they almost always are. A high business impact. Hello, you know, CMS is not reimbursing us for these anymore. Preparedness, okay, you're working on it. I'm prepared. We're doing everything we can. Internal response is high. You know, still, look at that at 2%. So that's a big deal. That's a good thing. So once you do all of these assessments, and it's a big document as you can see, you know, your total average risk score is 10%. That's pretty good. That's pretty good. But up here on the wrist, you've itemized which ones you need to work on. So this is how you go here. So look at this. So resistance microbes here. This is the next one. If you have a high incidence of multi-drug of MRSA, human impact is huge. Property impact, not that big a deal. Business impact, a medium. Preparedness, you're prepared. That's good. Internal response is good. External response is medium. You get 11% here. Look what happens here at the bottom of the page. If you've got no preparedness, everything else is the same, but your mitigation is a 1. Your internal response is a 1. Look at that difference there. So that's where you need to, this helps you to figure out what you need to do. So anything in the red is a big deal. It's high, it's a major, it's likely to happen, it's probable or it's unlikely, it's yellow or green, you know. There's a grid there that gets, red is an intolerable risk level, and you need to work on this like now. Come up with a plan. If it's tolerable, your risks must be reduced so far as is practical, and you know, you still need to work on this. And then in the green is acceptable risk level, even though, you know, we're all striving for 0. You know, one CLABSI after, you know, depending on how many central line days you have, you know, okay, maybe it was an IV drug user. Not that that's a good thing. We're seeing a lot of that. So what are you going to do to address that? That's all that's for. Okay. So here's another, this is a different assessment tool. This is just for emergency management, you know, so probability, possibility, impact, what's going to happen. A cyber attack, everybody has to be prepared, but the chances of having this is maybe not that big unless you were part of that big health insurance fraud thing that started, that was in the news a while back. Earthquake, this would be high or very high where I live. You know, I live within 30 miles of Mount Rainier, so this is a big deal for me. Facility fire, you know, this is all dependent on what you have available. So there it is. So 0 to 25 on this risk assessment is low. 26 to 40 is a moderate. 40 to 60 is considerable. I would get involved and do something about it. 60 is up. You need to do something about disaster planning if you're not set up for it. So then you put these on a grid and you assign them, you cross-reference the high impact versus low impact for material and the probability of this happening. So let's take Ebola, for instance. So if you're a critical access hospital, the probability is pretty low, right? But the impact, if you should just get that one patient that walks in the door, that was extremely high and was going to cause some major problems. So even though the probability was low, you still had to have a plan in case that patient walked in the door and you had to deal with this patient, you know. You didn't have to keep this patient for days on end or treat them even, but you should have had a plan to transport that patient to a facility that could take care of them. So in the meantime, you can't just leave them on the sidewalk, right? You had to take care of it. And so most of us came up with a plan to deal with that. Same thing. And all risks are a little different and some are very complex. So you have to consider all of this. This is a fishbone diagram, right, that helps you figure out what it is you need to assess. And if you've got, for infection prevention, if you've got a risk that is higher than you like, start here to figure out what, once you have it identified, then what are you going to do to address this risk? And come up with a plan using a fishbone diagram. So this is ours. I'll be very honest with you. This is, we didn't invent this. We stole this. We steal liberally, as do all of us in medicine. You know, you share liberally. Let's put it that way. This came from Minnesota. And we were very impressed with it. We found it online and we shared it with ourselves. So there it is. So you can see what this looks like. And this is part of your packet. you can go ahead and look at it. You can see there's a table of contents, and it talks about what our purpose is, our vision statement, our mission statement, and our scope of service. So this is what our facility, what our system does, and you have to corroborate this, your risk assessment for infection prevention, with the rest of your system. You don't just reinvent the wheel. You know, you have to make sure that it intersects with your facility so that you're all moving upstream together. Okay, it talks about our geography. It talks about possibility of terrorism, bioterrorism, evaluation of our effectiveness from the year before. So we had a risk assessment that we did in 2013, and we checked it against what we did in 2014, and because of that, we came up with our risk assessment plan for 2015 and what we did. You know, major incidents, those of you who were part of that pertussis outbreak that we had, you know, we learned a lot from that. So what do we do with that moving forward? That's in here. And so then we go into the risk prioritization about what we did. So let's move along. So this is just, you know, our treatment and services, our community, our geography, our population and care. So you get this stuff from your public health department. Your county health department has a lot of this stuff. And then you just have to be aware of your surroundings. You know, for those of you who have lived in this area forever, then you know what's going on. You know, but if you're new to the area, talk to people who are aware of what's going on. You know, if you're moved here to, for instance, I love this. My brother-in-law lives in Illinois, or my brother lives in Illinois, and they came out for a wedding. And, you know, Illinois is pretty flat, and they'd never been out here before. And he was just in awe of Mount Rainier, which looks to be like in our backyard, you know, from my house. And he said, I had no idea mountains were that high. And I go, wait till you feel one of our earthquakes. I said, then you'll pay attention to it. So, you know, every area is a little bit different. So this is, you know, it's adjacent to the Port of Tacoma. If you've got special things in your area, you know, make sure that you are noting that, geographic areas, because you are at risk for this. So get this. We are a busy port. There's a lot of ships in and out of Tacoma all the time. And you can actually go online and find out what ships are in port or are moving through the Strait of Juan de Fuca and into the South Sound. And guess what we discovered when we did this is that there are a number of ships that are registered for Liberia, which has been in the news much lately in the last year, right? And so we had to make sure that we had a plan that if anybody came off of that ship, that we would evaluate them as they walked in the door so we could know what their risks were for Ebola. So there's just more about our area. Mount St. Helens erupted in 1980. I was here. I was at work, actually, when that happened. And so that made it's always something that you have to address. Affordable Care Act. You know, the Affordable Care Act has come into effect now. And it was interesting. I noticed that we had a lot of very, very sick patients who had not seen a doctor in years, who all of a sudden were showing up at clinics and getting surgeries. And they were high-risk surgeries. You know, they were people who had ignored their health for a long period of time or had not had access. And all of a sudden, the acuity of our patients were a lot higher as they were going into surgery. And we tried to figure out what was going on. And as it turns out, it wasn't the affordable. It coincided with the Affordable Care Act. And so we have this built into our risk assessment now. So and as it turns out, all of our whole system is looking at increasing the access points for patients who now have health care, who are coming in, and so we can deal with them. Emerging pathogens. This is just an example of what it looks like, And if you want to share this with your facility, by all means, go ahead and do it. We don't care. We don't own this. You know, just make sure that what you do is attributed to your facility and to your area, so that you're not just cutting and pasting what we've put in this. So you've identified all your risks and everything for each risk. Now, pick the top 3, for instance. It's just, if you pick the top 10, you're going to be so diluted you won't be able to do anything effective. So focus on the top 3. For each risk, how will you measure what's going on? What are the actions you're going to do? You know, be very specific. What population specifically is at risk? What data sources are you going to use? How are you gathering this data? You know, when I was working in a critical access hospital, I also did all the micro. So I knew what was going on, and I would talk to myself and say, okay, you're seeing some MRSA coming out of these surgeries. What's going on here, you know? So that was my data source. Now I have data mining. Most of us in critical access didn't have that, you know, but you need to make sure that you're getting all of those cultures and that there are no surprises for that. And then what do you do with it? The method of measurement is very important. Are you going to measure by unit? Are you going to measure across the hospital? Or are you going to just focus on certain services that you provide? And then make sure that you prioritize, you know, the high risk, high probability, high impact stuff are the things that you're looking at first and foremost. So here's, this is ours. So this is our central line. This is just a really good example. Here's our central line bloodstream infections from our surveillance activity. This is our indicator. The goal is we had a goal. The number of CLABSI for this whole system will be 13 or fewer. That was the goal. Okay, so that sounds like a lot for some of you, but when you consider that, you know, how many patients we have, that over 5 hospitals, that would be a good thing, I think. Each business unit will include CLABSI reduction strategies as a major component of their quality. So that means each unit, when you say each business unit, which is, you know, by unit. Patient populations, all patients with a central line, both in the ICU and all the other units. Okay, so we don't just focus on the ICU, because the truth is the ICU pretty much rocked the CLABSI. They did a really good job and have eliminated almost all of them. Where were we seeing them? In the oncology units, you know, or in the regular med-surg units. And why was that? Well, guess what? We were instituted CHG wipes on a daily basis in the ICU, not just for the CLABSIs, but for every patient in the ICU got daily CHG wipes. Our CLABSIs almost disappeared when we did that. So we weren't doing that across the system for all patients. So what did we do? We identified who was high risk for these infections. Well, of course, it's the patients with a central line. So we instituted daily CHG baths in these patients, and our infections dropped, and we've been successful with that. So data entry, obviously, we all use Excel. If you don't know how to run Excel, take a class. There's a lot of really good ones online. You don't have to go to a formal class. You can learn it yourself. Obviously, we're all inputting data into NHSN now. You know, we use MedMind as a data mining program, which has been extraordinarily helpful. Obviously, you guys don't have that, you know, critical access. But if there's some way to work together with other hospitals with data, share your data. You know, it's not a bad thing to do. And make sure that if somebody, one facility or a friend of yours is seeing infections in their facility, find out about it. You know, share that information. Come to an APIC meeting. Talk about it. Method and analysis. So how are we going to figure out what's going on? We look at incidents, yes, and make sure that every infection is thoroughly investigated. You know, it's really easy to hide behind rates. And so we want to look at each and every one of those. So the priority score when we did all of this was 15, because we had system goals, We have federal and state mandatory goals for all ICUs and now across for all patients. So take a look at down here, case finding methodologies that explains exactly what we're going to do and how we're going to report it. And we're also adding, look at this, ambulatory infusion services. We added that last year. So it's a good thing, covering it all. Surgical site infections, the same thing. And I'm not going to dwell on this because I get involved in the weeds here, but I will tell you that last year we did not meet our goal for colon infections. And part of that is because we're a trauma center, and we had, you know, sometimes Tacoma is the gun and knife club, and we have trauma and violence out there on the streets. So, you know, these patients are higher for a possibility for infection, so we need to identify that and work very diligently for those high-risk patients, first of all. So, you know, what we did and how we managed that. And colon, obviously we're all reporting colon and abdominal hysterectomies now. We also at the state level, total knees, total hips, abdominal and vaginal hysterectomies, although vaginals dropped off, and have cabbages, of course. And we also report LAMIs and fusions. Now, C-sections we don't report anywhere, but we do report internally C-sections, and so that's always something that we're aware of around here. Plus the fact that we have very high-risk patients. We do all of the local area and a very large geographic area for high-risk pregnancies. So this is something that I get to focus on a lot, along with my friends in the OB department. So this is what it looks like. This is for surgeries, obviously. See, I've got the risk categories and risk factors, probability of occurrence, volume, and new. So high is a 5, low is a 1. Colon procedures, we had more than we wanted, and the impact was very high. The preparedness and prevention, we were pretty good. I mean, we had implemented a number of interventions that seem to be working, and now as we're going forward for the year, it's, I'm happy to say that we are below our target because of this. I'm really happy about that. You know, regulatory, yep, we have to do all of these things. And so the risk score for our colons for this year is a 12, which means that I'm spending a lot of time on colons, and that's a good thing. I'm going to 6 different meetings a month, sometimes 3 a week, to make sure that, you know, we're tracking and trending and everybody is aware of it. And it's nice to see. I have to tell you right now, we've only had 1 so far this year. So as others go along, you can see, you know, that we always have something going on. But colons were the big ones right now. So assessment process. So each risk category and factor is assessed. This is right out of our, copy and paste it out of our risk assessment. You can see what this looks like. See, any score grade 10 or greater gets special priority and is highlighted in red. So much for that. So we have about 30 minutes now to talk about TB. TB gets its own little risk assessment, and once you've done that, you have to include that in your facility risk assessment. And thank goodness, CDC has a great risk assessment that is part of your packet. You should be using it. That's the bottom line. You might not, here's the good thing. If you are spending a lot of time with TB, if you haven't done a risk assessment for a while, this is great because you might be doing more than you really need to do at this point. And if you haven't changed that practice, take a look and see what's going on, because you might be able to get off with less impact to your facility and to your time. However, if you've seen an increase, you might need to do more than what you've been doing, and you will have to add interventions and have to add education. So this is why a risk assessment is so good. How do you know what you're going to do? If you haven't looked at this, you have no way of knowing. So this is really important, and this is the link for that form, okay? And so we're going to look at that. So risk varies by the TB prevalence in your setting, in your healthcare setting, and the TB prevalence in your community. What kind of population do you have? You know, not everybody is the same. And which you also do a risk assessment for your healthcare workers. So, for instance, our lab does all of the TB testing and growing of cultures for the whole county. So their risk is higher. The folks who work with the actual TB cultures are at higher risk than somebody who's collecting checks in the finance office. So you need to make sure that your interventions are more with those people who have a higher risk than those who don't. And then you have to check and see what the effectiveness is. Just like in any risk assessment, the same thing goes here. If you've seen transmission in your facility, or if you've had employees that have converted, you've got a problem, and you need to address that. So, you know, obviously transmission is linked to close contact with TB patients during procedures and generating aerosols. So part of your risk assessment is that you need to look at these procedures. How many are you doing? What happens if somebody comes in and has one done? What are you doing for rule out TBs? What are you doing for just regular bronchs, for instance, you know, because how often has it happened? Patient has got pneumonia that just isn't clearing up, and the doctor wants to go in and take a look and get eyeballs on what's going on, and then boom, all of a sudden, or not all of a sudden, usually weeks later, you have a positive TB in that patient. So what are you doing to protect your healthcare workers if there's no possibility that this is a TB and then maybe it is? So what are you going to do about it for all of these aerosol generating procedures? So you have to develop an infection control program just for TB. So you do risk assessment in all of your settings. You can't just concentrate on where they're doing bronchs. Okay, you have to look at what happens when they walk in the door. Do you have clinics where patients walk in the door? We don't see that much TB in the hospital anymore, even for us. What we see is that patients come into a clinic and they just don't feel good. You know, it's grandma that's all of a sudden not doing really well, and she just came from, you know, some other country, and she's looking pretty puny, and now all of a sudden, you know, her granddaughter says, Grandma, we need to go to the doctor and check things out. So what are you doing in your clinic area? So it should be part of your overall infection control program. It's part of your risk assessment. This is just one part, but it's, as you can see, this is a pretty big part of it. And what are the likelihood that that patients are going to be seen? You know, it's not just it's not the TB we're seeing now. Usually is not like what it used to be, you know, from a Charles Dickens novel, okay? Usually it's just this TB that is just kind of there. They've had it for a long time and nobody's identified it. And so that's what we're seeing. So expecting to encounter TB patients. So you have to have if you're new to infection prevention, you need to become educated about TB. You need to know what's going on. The CDC has some really good things out there. APIC has some really good educational programs out there. You need to have a way to manage this. You need to collaborate with your local health department and the state to make sure that what you're doing is consistent with what the rest of the county is doing and then what the state is doing. Part of that is your risk assessment. You have to have a TB infection control plan, including protocols for identifying, evaluating, managing patients. You know, so for the most part, obviously, your county health department is going to manage these because most of these patients are managed as an outpatient. But, you know, when they walk in the door of your facility, what are you going to do with them? You know, for instance, I was at a surgery meeting on Wednesday, and I was talking about CHG wipes and how we want to get them out to the clinic so that patients will get them prior to surgery if they don't come to our pre-op clinic. And I had one surgeon that walked up to me. She's foreign-born, and she says, well, I have a lot of patients who are foreign-born, and they're coming to me because I speak their language. And I says, wow, that's just awesome. Good for you. I'm so glad we're, we're providing a service for these patients. And she says, well, what do I do if they are being treated for TB? And I says, so let me get this straight. You know they have TB. They're already positive. They're under treatment, right? And she says, yes. And I says, well, you should not be doing elective surgeries on these patients until they're done with their treatment and they're cleared up. You don't do elective surgeries. Now, obviously, if somebody's been in an accident or if they have something that has to be addressed soon, you can't wait that long. But we need to identify those patients and have a plan in place for how we're going to manage them. And she was just so grateful. She says, well, I know that they're not infectious. She says, because they've been cleared by the health department, but they're still under treatment. And I said, well, it would be to their detriment, right, to put them under stress to do a surgery, a big surgery on them if they can wait for it, if it's not something that has to be done today. So that was really nice, and that was just like out of the blue. I was there for some other meeting, so we need to be addressing that in the future. Testing and evaluate your healthcare workers. So obviously everybody who has a brand new employee, everybody gets tested. And you should all be evaluating them and then testing them and then doing education so that they know what the process is for your facility. So, and then what happens, what are you going to do when you have a new employee who's positive, and they have had no risks that they're aware of, who knows where they got it. So what are you going to do with them? Are they going to be able to work? Do you have a plan in place for how to evaluate and then possibly treat them? Who's going to do that? Are they going to be able to continue to work? All of that has to be addressed. And you need to, for patients, the coordination at discharge, who are you handing their care off to? Does their PCP understand the treatment of TB? Are they coordinating with the health department? All of that. Just because they're out your door doesn't mean that you still don't have to address their risk. What do you do if you have a known TB patient? What are you going to do with them? Do they have a room? Does your staff know how to deal with them? Do you have a way of following up? Does the staff even know what an exposure looks like, Most people, what staff usually does is, oh my God, I didn't know this patient was positive and now they're positive and I didn't wear my PAPR or I didn't wear my mask. And you go, now wait a minute, how much time did you actually spend in that room? Because not every exposure is a real exposure. So you need to make sure that you have a way of assessing that. Implement and maintain your environmental controls in all rooms. Yes, all rooms, and specifically for TB, make sure that you've got the proper ventilation. Who's monitoring that? How often are they monitoring that? And who's responsible? It's usually a finger-pointing thing, both pointing, it's not me, it's you, it's not me, it's you. And the truth is, if nobody's assigned to that job, then nobody is doing it. So you need to look at that. And then obviously ongoing training and education. So somebody has to be responsible, yes, and that's probably you. So if you aren't aware of it, it's time to start figuring that out. Make sure that you become friends with your local health department. That is so important. And make sure that you're all doing the same thing and are doing the same risk assessment. Collaborate, obviously I've said that how many times now. Get what's going on in the community from them because they know, and so that you're part of that. Go to meetings with them and talk to them. How many TB patients are they seeing and how many of them are your patients, and figure out who's going to be tested in your healthcare workers and how often you're going to do it. How many unrecognized TB patients do you think you're getting? And how many rooms do you need? Most facilities of nature of critical access, you have one room that is a negative pressure room, and often there's other patients in that room. What's your process for when a rule-out TB walks in the door and you need to get them in that room? You have to move that patient out and put them in there, make sure that you have a process in place so that everybody knows what to do. Otherwise, it can become a goat rope, to be very honest. I've seen it. You've probably experienced it, and none of it is fun. Identify, address areas with increased transmission risk. You know, if you are seeing transmission, where is it coming from? Who is there? Did everybody understand what was going on? Ideally, prompt recognition is most important. If you've got a radiologist looking at chest x-rays, make sure that they understand and know what that looks like and that they get you on the phone if there's something that looks suspicious, and that it's not just put in the chart and it's buried in a chart. It's really important that they understand that you need to know about these things. Once again, collaborate, you know, make sure you know what's going on in other areas. And so this risk assessment helps you to determine how often you need to do TB screening in your healthcare workers. So most of us come from the time when we did it. It was just part of what we did every year, you know, regular TB screening every year. The truth is, if your risk assessment, if you have a lower risk, you don't need to do that anymore. For us, for instance, yes, the people who are hands-on with the TB cultures, they get tested every year. Anytime, of course, anybody's had an exposure, they have routine testing, periodic testing. But, you know, for the most part, most of your staff doesn't need to be tested every year if you are actually a low-risk facility. Documents, make sure you have all the documents in place and you have a plan in place and all of that, how often, when it happens, who's getting transmission, and make sure you document negatives. You know, if you've had a patient come in and, you know, you've had some exposures, make sure you don't just go, shoo, that was close call. Make sure that you document that, and that's included in that. So that what that does is it proves that your risk processes are in place, and it makes it so that people aren't getting infection. That's good. So all settings should be perform risk classification. So if a patient walks in that door, you should have a risk assessment done for that facility, for that place. So here they are, the classifications. Low risk, persons with TB disease are not expected to be encountered. Exposure is unlikely. So some critical access hospitals, you know, you have a very low risk. Where I used to work, we saw one positive TB patient on 5 years. So we were a low-risk facility, you know. Sometimes you're a medium risk and your healthcare workers might or might not be exposed. And if you have potential ongoing transmission, obviously you're going to do a lot more testing, and your risk assessment points you to the fact that you need to do more and have a very robust TB assessment. So this is what it looks like. Inpatient settings less than 200 beds. If you have fewer than 3 TB patients a year, you know, then you're a low risk. How cool is that? If you have more than 200 beds, if you have fewer than 6 TB patients in a year, you're low risk, okay? If you have anything more, this actually, for most of these, your facility, if you're considered a low risk, you test your healthcare workers once they're new hired, and they won't have to be tested again unless they've had an exposure. Once they become, your facility is a medium risk, then you have to do yearly testing. And then if you have potential for ongoing transmission, then contact your health department, find out how often you need to test everybody, because this is a problem and you need to address this. So obviously, if you're a TB facility, this is a big deal, right? treatment facilities. Offices are different than in ambulatory settings. So less than 3 TB patients a year, you're low risk. So you might be doing more than you need to do. Excuse me just a minute. Anyway, non-traditional facilities, you know, we've got standalone emergency rooms these days, you know, so figure out what the risk assessment is and use that for what you're going to do and contact the health department. Some of you have long-term care settings, you know, and so they're a little bit different. Yes, patients who are in long-term care can have TB. You know, Granny has had it for years since she was 3 years old, and now her immune system's not working very much, and she's got a cough that doesn't want to go away. You know, do you have a way to assess that? Testing frequency low is baseline on higher. Further testing is not needed unless an exposure. Medium, it's baseline, and then do it annually. Ongoing transmission, wow, you know, this is a problem, you need to address it. And find out what the gaps are as soon as possible. So when you evaluate your infection control program for TB, time intervals are very important. Duration of all negative pressure precautions, you know, how often do you keep these patients in, how long, when do you determine that they're negative now? Have you met the criteria for putting them in isolation? Do you have criteria for having them come out of isolation? Does the patient have history previously? What are you using for treatment in your community? Obviously, you'll be dealing with the health department with this, but make sure that you contact physicians that have anything to do with this. There are a lot of people out there who think they know what to do, and when you talk to them, it's maybe not that apparent. Sputum collections. Does everybody know how to collect a sputum? And you'd think that some people do. I'll be very honest with you, they don't. So you need to have ongoing training to make sure that they're collecting the specimens properly. How are you handling that specimen? Most of you are not doing your own cultures. How are you transporting that culture? Make sure that you are aware of what's going on and if it's meeting criteria for prevention of infection. What do you do with those patients? Who are they going to? Are they followed? And are they going to your facility, one of your outpatient facilities afterwards? So you need to evaluate this annually, and if you have a spike in transmission or a spike in patients, reassess this. Don't wait for a year. Take a look at it right away and make sure, remember, this is a living document. You don't want to wait and just do it once a year without looking at what's going on in the real world. Take a look at your patient's records, you know, to find out what's going on. Get your eyeballs on it. Don't take it at face value about what people tell you they think is happening. And use data from the risk assessment in conducting what's going on. Testing healthcare workers, you know, we've already talked about this. Here's the thing, very often you've changed your testing from the skin test, and you're starting to use quantiferon gold. Hello, it's a lot more sensitive, and sometimes you will have false positives. So assess that, make everybody aware of it, because the testing methodology has a lot to do with how much TB you're finding. You know, you evaluate your environmental control and make sure that everything's working. If and this is my own experience, you know, we had a negative pressure room, everything was perfect, it had an anteroom, and we stored all of our PAPRs in the anteroom, and everybody understood where to go and what to do. And then somebody in the administration decided that they were going to change that room to a VIP room. And I wasn't involved in the discussion or the evaluation of what's going on. I came into work one day and they had torn my negative pressure room all up, and they were putting carpet, yes, carpet in the room, and you know, and so we didn't have a negative pressure room anymore, and so I had to pull rank and say that, you know, we can't accept patients who possibly have TB or other diseases if we don't have a negative pressure room. And so then there was a mad scramble, you know. So it's really important to always know what's going on in your facility, or at least have your foot in the door, if not a seat at the table, for all the construction activity that's going on in your facility. Aerosol generating procedures obviously are the highest risk, so you need to make sure that you've got adequate negative pressure spaces for that, and that people have the personal protective equipment for that while they're doing it. Because believe me, we've been burned by this before, where, you know, they're just doing a bronch on this patient, and you know, 3 weeks later the cultures are positive. So what's going on there? So classification example, you're a 150-bed hospital in a small city. You get 2 patients admitted in the last year. One was placed directly in a negative pressure room. One stayed on the medical floor for 2 days prior to placement. So, you know, the good news is that when you contact investigation and testing for anybody who had a possible exposure was negative. So, you know, now you're still considered low, you know. So that's good. So this, just review, but get this. This is one of the last screens. You know, I've given you some examples of tools that you can use for a risk assessment, but if you find another one, if you do some Google searches and you find one you like, by all means, use it, you know. Nobody's telling you have to do one way or the other, but you do have to do it. You can't just float along on the tides to figure out what's going on. Review your tool on at least a yearly basis. Make sure that it's still meeting your needs. You know, if you've added a whole wing on your hospital, for instance, the tool you used in the past might not work. So make sure that it's still functional. You know, most tools will meet regulatory requirements as long as you cover all of the bases and make sure that the risks out there are the ones you're actually looking at. And just make sure the process you use is complete. You know, go through all of the steps and make sure that this is a living, breathing document, and that you're using that risk assessment to determine what you're going to do to prevent infections for the next year. And that's it. You know, if you do all of this, and it sounds like a lot of work, and it can be, but, you know, if you do it just once a year and then reassess it like at 6 months or something, making sure that nothing's changed, it's good. It's good to go. Put a bow on it, and when the regulators or the inspectors or the surveyors walk in the door, you can hand that to them, and they're going to be a big smile on their faces, and that is such a good feeling, you know, because they know that you are on top of things, and it's always a good thing, and it keeps your patients safe, keeps your healthcare workers safe, and it makes it so you feel, at least if something's going on, that you'll figure it out what to do with it. And that's it. I'm out of breath.
Jeanette, thank you so much. This is Jamie. What we'd like to do, I know we only have a few minutes, but and we had a lot of information. So I do want to give our audience time to ask questions. Brenda, could you remind our audience of the process for raising their hand, and then also feel free to chat your question in the little chat window on your screen.
No problem. Hi, if you would like to raise your hand and ask a verbal question, look at the below your name. You'll see a hand, a check mark, an X. You'll see emoticons. Just raise your hand and I'll be happy to unmute you. Or you can use the chat panel to ask your question.
They're probably all in shock.
Jeanette, this is Jamie. While we're waiting for folks to work up the courage to ask a question, I want to just remind people that when you're doing the risk assessment, especially in the small critical access hospitals, you can consider contacting your local health department. You can contact other members in your community, like your emergency management office of your city, and they can do a lot of that risk assessment work for you because they're already doing it for their own settings, and then you can just piggyback on what they've already done. So that's another resource to consider.
Definitely. I'd invite them to sit down with you for the risk assessment because it makes it feel like everybody's on the same boat, you know. You don't have to be the only one with an oar in the water.
Right. And you may find that someone's already solved the problem that you're struggling with, and you can, like you said, share liberally with someone else who's already done it. Well, it does appear that you did such a great job, Jeanette, that no one has any questions at this time. So I will remind the audience that when you log off, we're going to have a SurveyMonkey evaluation for you to fill out. We encourage you to do that. Please know that we do review those. We'll share that information with Jeanette as well so that all our future webinars bring that information in so we can continuously improve. Also, if there's any particular questions that you still have, or if you have suggestions for us, be sure and put that in the survey as well, and we'll try to answer those questions for you in future webinars. Okay, with that, we'll sign off. Again, our next webinar will be June 10th. We'll be talking about survey readiness. I'd like to thank Jeanette so much for putting all this together and for spending her Friday afternoon with us, and along with all of the EQuIP members. Thank you again. You guys have a great weekend.